Hello, I'm M.M. Wiggins, and I'd like to welcome you back to Clinical Optics Made Easy. Today we're talking about accommodation. And in today's topic, we'll be discussing the ciliary body. We're going to visit with Emma once more. We're going to talk all about accommodation, maybe some donut cakes, and then how to work accommodation problems. And as we said before, here from Davis Street Studios, everything that I'm talking about is in Clinical Optics Made Easy, the second edition, which you can find at that QR code there or going to the website. But once again, you don't have to use that optics book. Use whichever one you want as long as you're understanding what you're reading and working lots of problems. So let's jump right in. Here we have a diagram of what's going on in accommodation. And there are 3 C's that go on whenever we accommodate. You can see them here. And although the pupils constrict and the eyes turn in, the contraction of the ciliary body gets all the press. And here's why we care about that. During accommodation, the ciliary body contracts, and then the tension that's on the zonule frees up and allows the lens to become the nice, round, fat thing that it likes to be. There was a lot of debate over this in the early years of ophthalmology, but von Helmholtz has won out. And this is the process that most everyone believes nowadays. The basic idea is that accommodation will move the focal point forward and making people more myopic. And you would want to ask yourself, why would anyone want to become more myopic? As you can see here in the bottom diagrams, that's just what's happening. You've got parallel rays coming in, focusing perfectly on that fovea, but when that ciliary body contracts and the lens rounds up and becomes more positive, adding convergence to the system, it will bring that focal point into mid-vitreous. And again, why in the world would you want that? Well, to answer that, we're going to visit again with Emma. She is our genetically perfect individual. She has the perfect amount of convergence between her cornea and her lens such that the rays entering her eye parallel are going to focus perfectly on the fovea, just like we talked about in Chapter 1. But once again, when Emma looks up close, you can see that those diverging rays hit her perfect converging system and they overpower her converging system and throws that focal point back behind the eye, and she becomes a hyperope, which is an emmetrope's worst nightmare. So what can she do about it? She can become an accommodating emmetrope. And when she accommodates, she contracts that ciliary body, adds just enough converging power to bring that focal point exactly onto her retina. It's kind of like her superpower, and she can control it very easily. She knows exactly how much accommodation to kick in there to bring it perfectly onto that retina. So if we look at this as a table, we can see that if I have an emmetrope with 3 diopters of accommodative ability, meaning that that's the most that I can possibly get out of my ciliary body, if I use none of it and I'm an emmetrope, I can see off to infinity because I'm a genetically perfect individual. Well, Emma is, maybe not me, but Emma is. If Emma kicks in just 1 diopter, she could see as close as 100 centimeters by kicking in 1 diopter. If she kicks in everything she's got, she can see 33 centimeters in front of her. She cannot see closer than 33 centimeters. That is her limit. But if she's a 3 diopter accommodative ability emmetrope, then that's what she can do. Having said that, we would say that her accommodative amplitude, which is the same thing as accommodative ability, is 3 diopters. Amplitude means the max accommodative ability. If we were to talk about her accommodative range, that would be the closest that she could see to the farthest away that she could see without any help other than accommodation. So her accommodative range, the closest she could do is 33 centimeters, and the farthest away she can do is infinity. Now, what if I had an emmetrope with 4 diopters of accommodative ability? That would give her an amplitude of 4, and now her range is infinity up to 25 centimeters, or 25 centimeters to infinity, however you want to write it. So that is the case for genetically perfect people, which most of us are not. If you're a hyperope and you're a convergence underachiever, once again, when you look at something up close, it makes everything worse. And so now you have to use accommodation just to get back to the retina to see off at a distance where those parallel rays are. So again, when the hyperope is not doing anything, when they're just sitting on the couch, not using any accommodation, they don't see anywhere when they're uncorrected. However, if they have enough accommodation, they can bring that focal point up to the retina and see off at a distance. And the truth is, if you look at all the world statistically, most people, or well, the greatest number of people are hyperopes. They're not emmetropes, they're not myopes, they're hyperopes. It's just that they're plus 0.25 or plus 0.75, and they can accommodate right through that, and they don't know that they're hyperopes. They're what's called latent hyperopia because they walk around for a good part of their lives and they don't need glasses and they think they're emmetropes, but actually they're tiny hyperopes. Now, in your clinic, you don't see these people, and that's why you have a skewed view of the world. You are seeing myope after myope after myope because they come into the eye doctor. Hyperopes of small amount typically don't. Now, the higher hyperopes, they have to because they don't have enough accommodative ability to get over their hyperopia. And the people that have kind of a medium amount, they will come in at a younger age because they will start to lose accommodation and lose their ability to overcome it. But the smaller hyperopes, you never see them until they get much older. Now, what if a hyperope wanted to see something up close? They would have to use their accommodation to get that focal point up to the retina just so they could see off at infinity. And then however close the thing was that they wanted to see, they'd have to kick in extra accommodation to be able to do that. So it's like they're in debt and they have to clear their debt to see off at a distance, and then it costs to see up close. So let me show you that in a table form. So here we're going to have a +3 hyperope, and they've got 6 diopters of accommodative ability. And you can see that if they're only kicking in 0 to 2 diopters, they're really not going to see anywhere clearly. Once they kick in that 3 diopters, they've overcome their 3 diopters of hyperopia, and then they can see off to infinity. But they still have 3 more diopters kind of in the bank, so to speak, that they could use. And so if they kick in 4, 5, or 6 diopters, they can now start to see things up close. They are limited, however, to just 33 centimeters because once they've used 3 of the 6 to clear their hyperopic debt, they have 3 left over to use for that. And so the closest they can see is 33 centimeters. Now their range is going to be 33 centimeters, the closest they can see, to infinity, the farthest they can see. Now, what if I have a 3 diopter hyperope with only 4 diopters of accommodative ability? Well, once again, they can use 3 out of those 4 diopters and see off at infinity. But if they want to see closer than that, they have to use whatever's left over. So in this case, they've already used 3, they've only got 1 left over. And 1 diopter will only buy you 100 centimeters up close because 100 divided by 1 is 1. So here you can see what their range and their amplitude would be. Now, what if we have a 3 diopter hyperope with only 3 diopters of accommodative ability? As you can see here, they have to use everything they've got to see off at infinity, and that's the only place they can see. So their range is technically infinity to infinity because that's, again, the only place they could see. Now, as we switch over to myopia, remember that these guys are convergence overachievers. They have a powerful cornea or powerful lens or a long eye. And for these overachievers, you can see that when they look at something up close, it pushes their focal point back onto their retina, and they can do that with no problem at all. You notice the ciliary body is doing nothing right now. So if I have a -3 myope and they have 2 diopters of accommodative ability, when they kick nothing in at all, they're just sitting on the couch doing nothing, they can see as close as 33 centimeters. But they still have 2 in the bank that they haven't used yet. It's like having a trust fund, I guess. Wouldn't know. But let's say that they added in those 2 diopters, and that is going to allow them 5 diopters worth, 20 centimeters, because they got 3 for free for doing nothing, and then they've got 2 on top of that. So it's a 5 total, and 100 divided by 5 is 20. So their amplitude here is 2, and their range is 20 centimeters. That's the closest they can see to as far away as they can see, which is 33 centimeters using no accommodation. If I have a myope with 3 diopters of accommodative ability, you can see here that they can see even closer, 16.7 centimeters, because they're not using their accommodation for anything else. They might as well use it to see really close things. Now here we have a younger myope with 6 diopters of accommodative ability, and they can see as close as 11.1 centimeters. So you can see that the myopes have a huge advantage when it comes to looking up close. And it really isn't fair. If you're a -3 myope, you can just hang out, do whatever you want to do, use nothing. You can see perfectly at 33 centimeters. If you're a perfect genetic being like Emma, she still has to kick in 3 diopters of accommodation to see the same as the myope who's doing a whole lot of nothing. The hyperope, that poor fella, he's got to kick in 3 diopters just to see off at a distance, and then he's got to kick in another 3 diopters if he wants to see at 33 centimeters. So he'd better hope that he's got 6 diopters in his accommodative bank, so to speak. So how much do you generate? You can see in this amalgamation of several tables of accommodative ability, age versus the accommodation that they have, and you can see where you are. Heaven knows where I am, but I can tell you it's way on down there. The important thing to notice here is, remember when we said that 2.5 diopters is a lot of times what you're going to put into bifocals because people like to read at 40 centimeters? The truth is, to comfortably use our accommodation, we only use about half. If you ask us to use our entire amount of accommodation, the eyes get tired, we don't like it, we won't do it. And so if you wanted to see at 40 centimeters, like a lot of people do, you don't use 2.5, you really ought to have 5 of accommodative ability so that you can just use half and comfortably do the 2.5. So as you can see here, who has 5 diopters? That starts to go away in your 40s. And what you will notice a lot of times is that people start to need their bifocals in their 40s, and this is why. So normally this is where I talk about why you care, but right now I feel like talking about why I care. So let's take a trip to the OR. So here we are, we're in the operating room. You're very happy to be there because you want to do some cataract surgery, and I don't blame you. You're in a surgical residency, why not? And here is your poor old attending here, and I'm sitting over here on the other side of the microscope, and then we have our anxious patient down there. And so right now, we've achieved what's called parfocality. Parfocality means that the objective lens, which sits at the very bottom of your operating microscope, has a focal length, and that focal length is right now focused perfectly where you want it, right on the anterior capsule or on the iris, but that plane right there is making everybody very happy. And so you can see that the divergence from that point up into the scope is diverging the rays perfectly onto your retina and onto my retina. That's parfocality. So right now, everybody's happy. But let's say that this patient, for example, has a lot of zonular laxity. So as soon as you put the phaco in there and you get all that pressure going inside the eye, the lens complex moves posteriorly. So you can see what happens from an optical point of view. You're now out of focus. So what are you, the resident, going to do? You're going to focus down. So what happens when we focus down? As you can see here, this is what happens with every microscope that I've ever worked with, is that the entire scope moves downward because you're pressing focus down on your foot pedal. And that is regaining that focal plane that you need to see clearly. But notice that the distance from the microscope to the lens never changed. It's just the location changed. It was just a sort of a vertical shift, right? But the distance between the lens and the microscope did not change. We just moved the microscope to regain our distance because the lens had moved. And because of that, the amount of divergence coming from the lens into the microscope doesn't change. And therefore, the rays that are coming up through there, and they're hitting probably some mirrors in the microscope and then bending 90 degrees, and they're hitting your retina and they're hitting my retina. So again, everybody's happy. Maybe not happy that there's zonular laxity, but happy that we've got a good view. But zonular laxity doesn't happen nearly as much as this next scenario. So here you are, you're a young resident, you're very excited to be here, and you're doing maybe your, I don't know, let's say your 4th or 5th case, and you're really going to focus on that rhexis, and you know what's about to happen. So I've reset the scope here. We're at parfocality, and let's get ready to do your rhexis. So right now you're focusing really hard because you want to do a great job. You don't want to screw up the rhexis. It's a really big part of cataract surgery. And as you're really focusing hard on what you're doing, You accommodate. And what happens when you, the resident, the circle on the right, accommodate? You are going to round up that lens by contracting your ciliary body, and you're going to make yourself a myope. But what happens when you do that? Everything from your perspective becomes blurry because the rays are no longer hitting your retina. Now, the old attending over here, we can see fine, and we don't know what you're adjusting the scope for because everything's great from our point of view because we're hopefully relaxed and we're not accommodating. Well, I can guarantee you we're not accommodating, but I can't guarantee you that we're relaxed, but hopefully we are. And so you can see the scenario here. So what are you, the resident, going to do? You're going to focus down. Now, why would you focus down? Because from an attending's point of view, everything is great, but you need to have more divergence coming from the object. So you want to move the microscope down, which is what focusing down again does. And you can see that now the distance from the microscope to the lens, because the lens hasn't moved, is a shorter distance, giving you a bigger triangle than before, and so more divergence. And when more divergence comes up through that scope, it's now going to push your focal point from the mid-vitreous all the way back to your retina so that you can see clearly and everything's great. But for the poor old attending who can't accommodate anymore because we're just too darn old, that focal point is now back behind the eye. And for us, everything is blurry. And that's when we're going to start fussing. So let's leave the OR and we should probably head back to clinic. I mean, there are patients there. It kind of is the right thing to do. And so you have a 35-year-old patient that comes in and she's a radiologist and she's getting headaches. You can see what her current glasses are here on top, and she's not getting to 20/20. She's afraid she's going to miss things reviewing images. And so you can see what the tech measured for you down here on the bottom. Wait a minute. Why didn't you do that manifest? You really should be doing manifest refractions if you're not, because once you're out in practice, I promise, your technician one day will have a difficult refraction and they will come to you, seeing you, the doctor, as the expert in all things, including manifest refraction, and they will ask you to manifest the patient and see if you're getting what they're getting, and you're going to be pretty uncomfortable if you haven't mastered manifest refraction. So at least do enough of those to get comfortable. It will pay off in the long run. So looking at her current glasses versus what's on the bottom here, what do you notice? I can tell you that I notice that she's gaining sphere, minus sphere, and she's gaining plus cylinder, and that is a myopic shift. If you're unclear why it's a myopic shift, it's because the spherical equivalent is shifting. So calculate the spherical equivalent for the top and then calculate it for the bottom, and you will see why she's going more myopic if there was any question in your mind as to why adding plus cylinder is a myopic shift. But the bigger question here is, why is this going on? So it's good to generate a differential diagnosis whenever you encounter acquired myopia. And the best way to do any differential is to look at it systematically. And so what would give you myopia to begin with? Increased power in the cornea, in the lens, in the ciliary body, which is our topic today. And so inside of each of these categories, there are lots of diagnoses. Here are some common ones, as you can see here. But we're not talking about tight contact lenses or diabetes. We're talking about accommodation today. So you suspect it's accommodation. How can you confirm that? Well, probably the easiest thing to do is to look back in the chart and see what her prior refractions have been. So here she is 3 years ago versus today, and you can see she is changing. So you're really suspecting now that she's probably accommodating through her refraction, and you want to know that for sure. Best way to do it is just to do a cycloplegic refraction. Patient's not going to like it, but it's necessary. So you can see right here, she's been way over minused, and that's a problem that you're going to have to solve. And I will tell you that it's not an easy answer as to whether or not you want to give her that prescription and let her walk out the door. I'm going to tell you that she's going to get that pair of glasses and they aren't going to work because she's so used to contracting her ciliary body at this point. Some people will give their patients a little cycloplegia for a while, but a lot of patients don't like that either. You know, you're walking around dilated all the time, especially a young person that's not used to presbyopia. It's really a tough spot that you're going to have to work through with your patients. So I encourage you to read more about treating over accommodation and what to do in these cases. It's just kind of a tough spot. that you will see in your practice, and you'll have to work through it on a case-by-case basis. So you're going to see accommodative problems in your career, whether it's in a testing situation or whether it's in the clinic. And we're going to walk through several of these just to kind of give you an idea of how to work them. And really, if we're talking about written accommodative problems, there's only so many questions that can be asked. And in fact, these are pretty much all the questions that you could possibly be asked. If there are more, I can't think of them. So here we have a patient that can see from 33 centimeters to 100. And usually in these kind of problems, this is the information that you're given. So if I have this sentence, I know that they can see as close as 33 centimeters as far as 100 centimeters. Well, if they can see no farther than 100 centimeters, they have to be a myope, right? Because a myope has their far point between the eye and infinity. So that helps me. And I know exactly where their far point is. It's at 100 centimeters. And so if I know that your far point's at 100 centimeters, 100 divided by 100 is 1, I now know that you're a -1 myope. And so if I'm a -1 myope, I'm getting kind of that trust fund easy money again, where I'm getting 1 diopter for free. And they're telling me that I can see as close as 33 centimeters, and I know that 100 divided by 33 is 3, so it takes 3 diopters to see at 33 centimeters. So if it takes 3 diopters to see at 33 centimeters, and I'm getting 1 just from my myopia, then I must be adding the other 2 through accommodation. And so if the question is, what is the accommodative ability here? It's got to be 2, because the total amount that they can see is 3 diopters, and they're getting kind of 1 for free. So if we go back to those questions, we've answered every one of those, as you can see here. So whenever you're working these kind of problems, here's what I recommend. It's a 3-step process. I don't think this would ever let you down. Certainly hope not. The first step is to figure out just who you're dealing with. Is it the myope, the hyperope, or is it genetically perfect Emma? And then you have to figure out how much free money or free diopters does the myope get versus how much debt is the hyperope in. And then step 3 is to figure out how close can they see, and that is the total dioptric buying power to do that. And then you can kind of figure any of those questions out. So let's go back. Here we had a patient that can see 33 centimeters to 100. Step 1, we figured out they were a myope. Step 2 is to figure out how much they have in the bank or how much debt they have. And so we figured out that because their far point was at 100 centimeters, they're a -1, so they get 1 for free. That was step 2. Step 3 is to figure out what's the total buying power. It tells you that it's 33 centimeters is as close as they can see. So we knew that was 3 diopters. And once we had that, and we knew they were getting 1 for free, it was pretty easy to figure out the accommodative amplitude. Now, sometimes when it's your birthday and your parents ask you what kind of cake you want, and you're a kid, sometimes you just want what you want. And if you want a donut cake, by golly, we're going to get you a donut cake. That was awesome. Here's a patient who can see from 20 centimeters to 50 centimeters. So what do we know about this patient? Let's work it through the steps. So if 50 centimeters is the farthest away that I can see, step 1 is to determine myope, hyperope, or emmetrope. It's got to be a myope. I mean, it just has to, right? Because a hyperope, they can't see at 50 centimeters doing nothing. They can either see at infinity if they have enough accommodation, or they can't if they don't have enough accommodation. But 50 centimeters is never going to be the answer for a hyperope, right? So this must be a myope. And we know that the far point is 50 centimeters away, so what myope has a far point 50 centimeters away? What's 100 divided by 50? It's going to be 2. So if I'm a myope and I'm a -2 myope, I'm getting 2 diopters for free. I'm getting those genetically. So once I have that, it's time for step 3. What is the total buying power? And it tells us that they can see as close as 20 centimeters. So how many diopters does it take to see at 20 centimeters? It takes 5 diopters, 100 divided by 20. So if I have 2 for free and 5 is my total, I'm kicking in 3 through accommodation. So that answers kind of every question that we could have had about that patient. Here's a patient who can see from 25 centimeters to infinity. Okay, so already before I read anything else, if they can see to infinity, I'm not dealing with a myope. It's either a hyperope or an emmetrope. And I can tell you that on accommodation problems, emmetropes are unicorns. You're just not going to see them very often. Hyperopes, you'll see quite often. So let's continue on. So 25 centimeters to infinity, I'm betting it's a hyperope. And they're fully corrected with +2 glasses. Now I know they're a hyperope. I know they're a +2 hyperope, right? Because it's giving me all of that in the question. So here's what we know. We know that there are 2 diopters in debt. And then if these were some of the questions, you would already have all of that. So what is the total buying power? We're already on step 3. Number 1, we figured out it was a hyperope. Number 2, we figured out 2 diopter hyperope, so 2 diopters in debt that they have to get over before they can even think about seeing something up close. So it tells us that I can see as close as 25 centimeters. How many diopters does it cost to see at 25 centimeters? It costs 4 diopters. So if it costs me 4 diopters to see at 25 centimeters, and I've got to get rid of 2 diopters before I can even start on that 4, then I must have at least 6 diopters in the bank. Actually, I would have exactly 6 diopters, because if I had more than 6 diopters, I could see closer than 25 centimeters. So accommodative amplitude here must be 6. If that doesn't make clear sense yet, hang on, we're going to do some more. Here I've got a patient that can see 33 to infinity and corrects with +3 glasses. Well, right away, it's starting to become a little easier. They're telling me that it's a hyperope. They're telling me it's a +3 hyperope. So I've got 3 diopters of debt to get over. So here we go. Here's what we know, in case this was what was being asked. Notice how I'm not showing you what question of those 6 or 7 questions that they're asking, because in this system, it doesn't matter. You use this system, you're answering all of them. And so it should be comprehensive for you. Okay, so I've got a 3 diopter hyperope, and they can see as close as 33 centimeters. So again, how many diopters does it take to see 33 centimeters? It takes 3 diopters. How much debt do they have before they can start working on those 3 diopters? They've got 3. So now I have a total of 6 diopters. That must be what they have in the bank. So here we've got a patient that can see from 50 centimeters to infinity, and they've got an amplitude of 2 diopters, and we've got to figure out who are we dealing with here. It's clearly not a myope. This is interesting because the closest they can see is 50 centimeters, which costs 2 diopters, and 2 diopters is all they have. So how does that work? Because if you're a hyperope, you have to spend some of your accommodation to get out of your debt before you can look at something up close. But they're using their entire amplitude here to see up close. That is your clue that they had no debt to begin with, and that is the unicorn, the emmetrope. And of course, the emmetrope can see off at infinity. That is where their far point is, and they correct with a whole lot of nothing. So an emmetrope has no debt, and they already told us how close they could see, and so they cannot ask us the accommodative amplitude on this one because it's given in the problem. But I wouldn't worry too much about this, because you will likely never see an emmetrope on a testing situation. So here we've got a patient that can see 50 centimeters to infinity, and they've got an amplitude of 4. So the 50 centimeters, which would be 2 diopters, does not equal the 4 diopters. So we're not dealing with a unicorn here. We're dealing with your run-of-the-mill hyperope. So that is our step 1. We've got that figured out. You can see here with the accommodative amplitude of 4, they've already told us step 3. We already know their total buying power. So this must be kind of a step 2 question, asking us how hyperopic are they? How much debt do they have? What pair of glasses would you prescribe? All asking kind of the same thing. And so the way you would do that is you would say, well, if I've got 4 diopters of accommodative ability and I can only see as close as 2 diopters worth, then I must be using 2 of my 4 to get out of debt. And so that tells me that I've got 2 diopters of debt. It tells me that I would use a +2 to treat this patient. And where would their far point be? 100 divided by 2 is 50, so it'd be 50 centimeters behind the eye. And so by kind of doing step 2 last, which this problem is forcing you to do, you can answer all of these questions. It still uses the same method. Let's work another one. Here's someone that can see 25 to 33. Ooh, they're not seeing to infinity, so we're not dealing with hyperopes anymore. This is a myope, and they have an accommodative amplitude of 1 diopter. So I know it's a myope. And let's see, where's that far point going to be? They can see as far away as 33 centimeters, so that tells me where the far point is. And if they have a far point at 33 centimeters, they must be a -3. So if they're a -3 myope, that's how much they're getting for free. And did I even need to know that they had an accommodative amplitude of 1? I don't know. Is there anything else that I need to work here? I think we've kind of answered all the problems. Everything else is kind of given to you. Okay. Don't know what else we could ask on that one. We kind of had that one pretty quickly. Here's someone with an amplitude of 5 diopters, and they're fully corrected with +3. Okay. If I'm fully corrected with +3, I'm a hyperope. I'm a +3 hyperope. My far point is 33 centimeters back behind the eye. So how far away can I see? Well, if I'm a 3 diopter hyperope and I've got more accommodative amplitude than my det, I can see as far away as infinity. How close can I see? Well, let's see. 3 of the 5 diopters were used to get me to see off at infinity, and then I've got 2 diopters left over. That would be 50 centimeters up close. So that would be as close as I could see. So I would be able, my range would be infinity to 50 centimeters. Hopefully that makes sense. In this problem, we see accommodative amplitude of 4, but a near point of 20 centimeters. And we know that the cost of 20 centimeters is 5 diopters. And so they are spending 5 diopters to see up close, but they've got 4 in the bank, which means they must be getting 1 for free. So that tells me right away that we're dealing with a myope, and not just a myope, but a -1 myope. So the far point has to be 100 centimeters. And in fact, that kind of tells me everything that I could possibly ask on a question like this. So that one wasn't too bad. So here we've got a patient that's fully corrected with -3, so telling us right off the bat that we're dealing with a -3 myope, so I'm getting 3 free diopters. I don't have to think to know that. And then once again, I have as close as I can see is 20 centimeters equaling 5 diopters. So if I'm getting 3 for free and the best I can do is 5, then how much is accommodation kicking in? Pretty straightforward math there. The accommodation must be 2. And so I suppose that kind of answers everything that we could possibly ask. I mean, I suppose you could ask, what is the range? Range would be 33 centimeters to 20 centimeters. I just don't know what else we could possibly ask here. This was about as straightforward as they get. Let's work one last problem. Want to? So here we've got a patient that can see 25 centimeters to infinity, and they've got 6 Wait a minute. It's asking how close can he see when wearing 2 diopter glasses? We haven't done a question like this. How do you work that? I can tell you the best thing to do is just ignore that second statement altogether. Just take that first statement and do what we've been doing over and over. So I've got someone that can see as close as 25 centimeters. That's 4 diopters worth. And they've got 6 diopters in their bank. So they have spent 2 of the 6 seeing to infinity, and then they had 4 left over, then that's how they can see 25. So if they are spending 2, that means they've got 2 diopters of det that they're covering there. So they are a +2 hyperope, 50 centimeters behind the eye, yada, yada, yada. You know how to work these problems by now. So that's the first thing you do. Now, let's get to that second question. We know who we're dealing with here. They have 2 diopters of det. I'm going to now give you 2 free diopters, which is what glasses are, and I'm going to cover your det for you. So you've got 6 in the bank, and you can now use all 6. You don't have to use 2 to cover your det. Your glasses are doing it for you. So now you're just left with those 6 diopters that you can spend entirely on something up close. So what is 100 divided by 6? Remember from that first lecture, we said that we were going to learn what 100 divided by 6 was because that's going to come up over and over. And that answer is 16.7 centimeters. Well, that's it for accommodation. I appreciate you spending some time with me today. This was a very high yield topic. It comes up over and over again in practice. It's very easy to write these kind of questions, so it's very likely that you will see this in a testing environment. So do lots of problems, really understand this, have this down cold, and then come back and join me for our next lecture where we're going to hit another high yield topic called magnification. So y'all have a nice day. And once again, thank you for joining us here on Clinical Optics Made Easy.